So the diabetes service looks after approximately 200 children and young people, and we run clinics on 2 hospitals, City Hospital and Sandwell Hospital. The service covers some of the most deprived areas nationally, and the proportion of unemployed in our area is higher than the national average. And we serve quite a diverse multi-ethnic group. So that gives us an idea of where I work. In the last published National Diabetes Audit, the median HbA1c for Sandwell was 7.7%, and City had a mean adjusted HbA1c of 7.8%. 42.8% of children attending Sandwell Hospital had HbA1c less than 7.5%. So we realized that the everyday reality for our families living with diabetes is a constant juggle just to get a balance and get good control. And essentially, parents and young people are responsible for managing their diabetes. Most of you would have seen this quote, that most people with diabetes spend only 6 hours a year in contact with healthcare professionals, and they have to manage most of the time. So realizing that helps us to develop our strategy. One of the key empowering messages we give is that diabetes indeed is a serious condition, but with good control, they can significantly reduce their risk of complication. Their condition is essentially well self-managed, so they need the knowledge, the skills, and the can-do attitude, as well as the support of the healthcare professionals to be able to manage. So that kind of underpins a lot of what we do. There are 6 essential self-care behaviors we have identified. We review these at annual review and opportunistically in clinic at different contacts. We think they need to have the ability to monitor their blood glucose, and more especially to be able to keep either a paper or digital diary, so whatever works for you, so that you do review your numbers regularly. We think they need good problem-solving skills. So they need the ability to use correction doses, and they need to know how to adjust their own insulin dosages using pattern recognition. In our clinic, we call it the 3-day rule. So we sometimes say, can you show me where you're following the 3-day rule? That is using pattern recognition to adjust your own insulin dosages. Healthy eating, including ability to camp count, sick day rules, but they also need healthy coping skills and risk reduction behaviors. The other strategy, evidence that underpins what we do is that we realize the importance of the first year. Both the DCCT and EDIC study confirm that metabolic control in the early years following diagnosis is very important in reducing rates of long-term complication, the so-called metabolic memory. So how do we integrate all this evidence in our clinic? So from diagnosis, we aim to develop their problem-solving skills. So in addition to the survival skills, we stress the importance of getting to a target of 4 to 7. Now, we work in an area where we use interpreters, education rates are variable, so simplicity is the key. So we try and simplify everything. If an 8-year-old can do it, then an interpreter can explain it to a parent. So we simplify the use of correction doses to get to targets. So there will be people who will understand the concept of insulin sensitivity, but many in our unit might not understand it. So we'll give them simplified algorithms. So if your blood sugar is more than 8, give X amount. If your blood sugar is more than 15, give X amount, so they know what to do. And I've said before, we teach them pattern recognition so that they can use that to adjust their insulin dosages. And we use a very simplified approach to carbohydrate counting. We go in multiples of 10s or 5s to make it very simple. And we offer telephone support. In terms of the importance of the first year, we work towards aiming for excellent control from the start. So following discharge from hospital, they get daily contacts from our nurses for the first 7 days. A lot of that is support and education. They also get very frequent clinic appointments. So I would see them the next week after they're discharged, and they will get up to 7 clinic appointments or more in the first year. Telephone contact 1 month following a clinic, and all are invited to a revision group structured education a year. What about psychosocial support? All our newly diagnosed patients with diabetes meet with our psychologist whilst they're still on the ward. It's really to introduce himself, and the aim, he says, is to normalize the role of the psychologist as a member of the MDT so that they feel able to contact him and so on. So it's not like seeing the mental health person. He doesn't actually see them formally until 3 months. So he sees all of them, gives them a 3-month appointment, because he thinks the turmoil of diagnosis and reaction to that are all normal. So unless there's something extra happening, he doesn't formally see them at 3 months. Then he checks on them to see they're okay. We have what we call a monthly psychosocial meeting, and it's a meeting where we discuss only one child. It lasts an hour, and it will be perhaps a child we're struggling with. We invite stakeholders, which might be in school. The aim is for us to really understand that child, their family, what makes them tick, why are they struggling, etc. It's a professionals meeting, but sometimes we invite the family as well. And we then have action plans and so on. We do, as everybody else do, the annual assessment of psychological well-being, and we also do opportunistic assessments before we change therapy, etc. In terms of structured education, our step-up program is essentially a revision course. So every single family is invited. It's age-banded, and it depends on what group they fit into. Children and young and their families come. The parents are in a different group, and the children are in a different group. In addition to the group structured education, everybody gets a one-to-one education at diagnosis and annual review. And before we give you any equipment, we make sure you know what you're doing with it. So before you go on a pump, you attend 3 pump schools, which is 2 hours each. 6 hours, usually 2 weeks apart. And before you go on a CGMS, you go on a CGMS school. And before you go on an FGS, you go on an FGS school. So at the structured education, in addition to the usual topics, I've said it's a revision course, we also discuss other issues, like sharing diabetes tasks. So is this question of whose diabetes is it anyway? So it's not unusual for us to suggest for our families that they set out a day in a week where they get together, review their downloads, and agree what needs to be done. Talking diabetes, so using a problem-solving approach to react to abnormal blood glucose. This encourages the young people to open up to their family. And treating your diabetes as your personal dog, so love it, walk it, feed it, and it will be your best friend. Ignore it, and it will bite you. And also the importance of praising and nurturing children and young people with diabetes is sometimes easy to forget that there's a person at the end of those numbers, and in the quest for good control, the diabetic child can become a non-person, you know, with everybody nagging and so on. So there's always something to praise, finding those things. We talk about conflict resolution as well. The third concept is the importance of whole team approach. So you can see what our 2009 result looked like. The city hospital had median HbA1c of 8.6, but only 10% achieved HbA1c less than 7.5. In In that year, Sandwell had median of 8% and a quarter had HbA1c of less than 7.5. When the two services merged, we agreed a team philosophy, which is about self-care, promoting self-care amongst our families. We have annual away days so that we agree targets, we agree strategies, we agree a common language. We also assess team training needs. We have regular joint team meetings and joint clinics. And you can see that the results for City and Sandwell are very similar now because we are one service. How do we improve completion of care processes? This is our results for 2014-15. Apart from microalbuminuria, you can see that all the other results were above 90% completion. And this is by having a structured approach to clinic review. So before any clinic, our secretary will interrogate our database and print off for every child coming to the clinic what care processes they need or not need. We review that report before clinic so that everybody is quite clear what needs to be done. We use a structured clinic performer. We also have a post-clinic meeting with actions. And this is where we have, so it may be target phone calls or target home visits. Sometimes we repeat HbA1c in 6 weeks. We don't do this often, but when you have a young person that is doing very well and starts to deteriorate, rather than wait until it becomes a problem, we might agree a strategy with them, and then to try and keep them motivated, we say, well, we'll come and do an HbA1c just to make sure. So seems to work. Every September, our secretary will send a letter to our families and GPs to remind them to attend retinopathy screening, to have their flu vaccination, etc. And our clinic letters at the bottom has some key messages, including out-of-hours contact numbers, care processes completed, etc. And we try our best to have a patient-centered approach, encouraging problem-solving at clinic. So it's quite common for us to ask the families or young people what changes they think we ought to make following download. Because they all know how to adjust insulin dosages, so it's usually interesting to find out what they want, and then we agree with them, or if we think it's something else, we explain why it could, it would be another difference. Where possible, we use motivation interviewing, and we review self-care competency skills, what they have attained, formally at annual review and opportunistically. And it's not uncommon for, during a clinic, for the nurse to have to take a family to another room to do target education on an area that we've identified they need a bit more information on. So to conclude, our ultimate goal is really to try with our families to get a balance so that they achieve well-controlled diabetes. But the young person is happy and well-adjusted, has normal friendships and normal family life. Thank you.
Any burning question about what you've heard? Because the structure of what Chizo is doing, it's incredibly commendable, isn't it, to manage to do this and show those improvements. So there's a lot of lessons to be learned, I think, from how you go about providing your service, Chizo. Any questions that are relatively nearby to save time? This maybe, hang on, you can use my microphone. How's that? I'll just come. Because you're nearest. There you are.
Thanks, Chizo. You mentioned about the deprivation in your community, and I just wondered whether you have any particular approaches to families from a socioeconomically deprived background from the outset to try and engage them in your service.
I think we have high expectations for all our families, and simplicity is the key. I think if we try and explain things, there's some people we teach using pictorial, I talked about simplified correction doses, that we have people that can't read or write. We teach them to count on their fingers to be able to do it. So I think is saying to every young person that comes our way, we expect you to do well, and it's our job to understand the physiology, the principles, and then break it down to the level that you can understand, and then give fairly strict messages at the beginning, because they don't know any different. So if you say, this is how it's going to be done, and this is what, but that's why we have all that support, daily contact, because the vast majority of our families are from low socioeconomic families, and I don't want to use the word dysfunction.
Thank you very much. And I think one more, Marcia, I think you...
Yeah, just curious, you said you provide 24-hour telephone support. I was just wondering how you resource that. How do you do that?
It's in 2 stages. We have a rota that involves 5 of us, 3 diabetes nurses and 2 physicians. Out of hours, the first contact is to the registrar, who then calls us. So if the registrar is not able to answer the question, and at induction, it's quite clear exactly what they can or cannot answer, and if they're not able to answer that, they call us at home, and then we answer. So we've got a 24-hour rota, but out of hours, the first contact is the registrar. And I do say that to the families at the end. I said at the beginning, I say, when you phone out of hours, you will either get a message, an answer straight away, or somebody will call you back within quite quickly. So they might just take your number, and then we call you back. So it's not direct contact with us.